Good morning, everybody, and welcome to this edition of Macro Pro and Friends webinar series. I'm joined by my longtime friend, Dane Taylor. Dane, how are you today?
I'm doing great. So good to be on here with you, Diane. Thank you so much for inviting us to share some information about brain injury rehab.
Yes, well, you're welcome. So, how long have we been doing this together? Do you remember how long it's been?
Oh my gosh, I can reflect back to the years and years ago, where you helped spearhead this whole idea of education for adjusters that is offered for free. And I remember working with you on some of those projects so many years ago. I'm going to say maybe 15, 20, I don't know.
I have a recollection that we did a Carl Van event in 2002, maybe three. So that
Oh,
would be 20
yes.
years. And
Yes.
believe it or not, we're going to do another Carol Van event in Roseville in November. But yeah,
Wow.
nobody at the time was doing free education. You're right. I totally forgot about that. Thank you for bringing that up. That
Well,
is really
thank
cool.
you for continuing it, and you have just taken this ball and run with it, and you've offered so many great hours and hours of education for everybody.
Well, thank you. Might as well plug our YouTube channel. A lot of our programs you can find on YouTube. We started doing that after the pandemic. So there's not years and years of information, but there is a couple years. They're great videos. You don't get CEU credits for it, but you can go to the Macro Pro YouTube channel and watch that. So Dane, before we get started, I got a little bit of housekeeping to do. So for those of you in the audience, I wanted to let you know that today's event is worth one CEU. You must be logged on to the GoToWebinar platform, which means use that link that they send you as a reminder. You'll get your certificate in roughly an hour, 2 hours, and it should say something like your certificate has arrived. Make sure that you download that immediately. If you to have problems, it'll like do a green little button that will swirl, 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 and then eventually the certificate will show up. But if you have problems with that, it's probably an issue with your firewall. So check with your IT department. And then handouts. We have some great handouts today on our program and on CNS and what they do. So make sure you download that. If you have any questions, Dana and I will be monitoring that. Our expert today, Alex, will be happy to take your questions, and just type it in. We're going to go ahead and interrupt her and see if she can answer that question so it's near the point of what the discussion was. And then I'd like to add one other thing, simply because today we are talking about nurses and brains and medical. MacroPro does have a brand new service that some of you may not be aware of, and it is called a medical focus summary or synopsis. And what it is you let us know what injury you're looking for. You tell us what body part it is, and our nurses will do an injury focused synopsis for you and provide you with just the relevant pages. So if you are trying to send pages to a QME that you don't want to send more pages than you need to, this is the perfect product for you to be able to do that. And we're happy to do that. If you have any questions on that, you can always email me, or you can ask your Macro Pro sales manager. All right, Dane, do you want to introduce Alex? Because today Alex is, well, before we do that, why don't you tell everybody what you do for CNS?
Okay, well, I am the National Director for Payer Relations, and Center for Neuroskills is a post-acute brain injury rehab facility. We have 3 locations in California, and each location is also capable of having inpatients in one of our residential programs. We have a variety of programs. We have houses and we have apartment buildings that we manage and run. And this is what's so exciting is Alex is going to be explaining the residential program of CNS. CNS has 2 programs basically in one. We have the residential program and then the clinical program where they receive OT, PT, speech, counseling, all under the same roof. And this creates a great collaboration between the clinical and the rehab, the residential rehab, because at the residence, they're going to be learning their everyday daily living skills that we all take for granted. So that's basically about CNS, and I will go ahead and if you want,
I'm gonna stop you for half a second because since we're on this memory lane, I can remember back years ago when we first did this program and was doing free training. I'm gonna give them a shout out. LWP had inherited some cases from a different TPA, and they had a young man that had a traumatic brain injury, and he couldn't live with his family because he was violent and mean, and he didn't have skills anymore because of his brain injury. And his family, of course, was grieving the loss of this wonderful husband and father that they had. And LWP said, you know what? It's been a couple years. Is it too late? And you guys said it's not too late. Let's work with him. And I think it was about 2 or 3 years later, the adjuster said to me that the dad was able to come home for weekend visits. And
Oh,
I'm sure by this point he's home all the time. But if it wasn't for your program and an examiner who was willing to do the extra steps,
that's
look at that.
right.
Choked up. I just love what we do. I just
I
love
know.
what we do. Okay, so let's introduce Alex.
Okay, so Alexandra Roscoe, she is one of our residential rehabilitation managers in the San Francisco clinic. It's based in Emeryville. And she has such a deep experience in post-acute care in different settings. She's worked with pediatrics, trauma, stroke, traumatic brain injury, and assisted living. She started with CNS in 2017 and has served as an occupational and lead therapist. She serves a broad array of different types of patients, and her education is very vast. She holds a MS in occupational therapy and has earned many certificates in all different spectrums of the patient care. So I just want to introduce Alex. We're very excited to have you on board today.
Thanks so much, Dane. And yes, just like it was stated, if you have any questions as we're going along in the presentation, please just type them into the box and we can address them in the moment so that we all remember the topic that we're on. So today we are going to be diving deep into why residential treatment is essential in recovery from a brain injury. We are going to be recognizing that residential treatment has a place in the care continuum and kind of where it fits into that continuum. Also, we are going to talk about how residential treatment promotes transition to the home setting, trying to get people into the least restrictive environment and back into the community. Understanding how residential treatment impacts learning and how that plays a role in neuroplasticity and skill development. And then also understanding how residential treatment can promote positive behavioral change. Lastly, we'll be discussing environmental validity and really how setting up the residential facility in a way that complements the patient's previous routines, roles, and rituals can enhance the rehab process. So, why is this so important? It's because there's a lot of people who acquire traumatic brain injuries. So every 9 seconds in the US, someone sustains a brain injury that correlates to 2.5 million people every year. And of those injuries, 1 in every 60 people, so more than 5.3 million Americans, live with a disability from that TBI. So the primary causes, and we've seen people come into our clinic due to all of these causes, would be from falls, and that can be falls from a height, like from a ladder or scaffolding, or slip and falls on the floor. Motor vehicle accidents, blows to the head, including sports injuries. So, we see a lot of football players, soccer players, cheerleaders, and then different types of assaults as well, so firearms or any type of attack. And then just a category for other, because there are 1,000,001 ways that you can become injured. The peak incidence for ages would be ages 0 to 4. And if you think about the causes of these accidents, we're looking at our largest contributor is from falls. Think of what you're doing between the ages of 0 and 4. You're learning how to walk. So there's a lot of tumbles and falls that come with that. Ages 15 to 24. So if you think about yourself during this time frame, you are learning how to drive typically. So we do see a lot of the motor vehicle accidents from this age group. And then also 65 plus. And again, that kind of cycles back to having a lot of different falls. And you know, we're no longer learning how to walk, but our muscles and joints and bones are getting weaker, and we're starting to see that decline because of age. So the consequences of brain injury are vast. So the brain does control every little piece of what you do, what you think, how you feel. It controls your body, your emotions, your cognitive processing. So the consequences of brain injury can affect your motor and sensory participation, meaning your coordination skills, your strength, your endurance in your limbs and your body, as well as how you are able to perceive sensation. So whether it's an injury to the nerve, maybe there's a concomitant injury in your limb, or the way that your parietal lobe is perceiving that sensation can be disrupted. Also, communication skills. So these can be impacted in several different ways. We can see patients come in with aphasia, either receptive aphasia, they're not understanding words that are communicated to them, expressive aphasia, so they know what they want to say, but they just can't get the right words out. Sometimes they have both of those together, so known as a global aphasia. And then other times it's a result of motor and sensory impairment, but to the muscles of the mouth. And we see that play out with dysarthria, where people have a hard time coordinating the small muscles of the mouth and tongue to produce clear speech. Also, the emotional consequences. So we will see a lot of different types of maladaptive behaviors from patients, and this could be due to how their brain is now processing emotions. Sometimes people will be quick to anger or experience crying episodes, and sometimes the patients are very aware that these things are happening and they just cannot stop them from happening. I recently had a patient come in who said, I know that I'm angry all the time and I shouldn't be, but I can't stop. And other times there will be a lack of awareness of that emotional volatility, and they just won't realize that they're over or underreacting to situations. And then there's, of course, the cognitive component. So how is your brain processing information? Can you sustain attention? How are your executive functioning skills for problem solving, planning, time management? And we'll get into more of that later on in the presentation as well. And the psychosocial component. So one thing that we offer here is counseling to both patients and family members, and a lot of it is focused on adjustment to disability. So they're going through this huge life change. How is that affecting their roles in the family? How is that affecting different relationships in their life that are being affected by this injury? So when we look deeper at the medical complications of traumatic brain injury, we will see that this population is 1.5 to 15% times more likely to develop a seizure disorder. And sleep disorder is reported in 70% of outpatients. So that can be disrupted sleep for a number of reasons, including sleep apnea, periodic leg movement, so you may have heard of restless leg syndrome. And then also a greater risk for neurodegenerative diseases. So when we think of brain injury, we don't just think of it as a one moment in time injury. It's the beginning of a disease process that puts you more at risk for these different post-traumatic morbidity symptoms throughout your lifetime. We also will see this impact your neuroendocrine system for some of our patients. One thing that we test for here when we see red flags for this disorder would be growth hormone production. A lot of our patients will have decreased human growth hormone, and that just affects your overall fatigue levels, and your ability to perform in therapy and participate in rehab. We also see metabolic dysfunction and just different variations in the way that the body and the brain utilizes things like glucose, for example. Sometimes we'll see a slowed down use of glucose in the brain, which affects your quickness and speed for processing information. In addition to this, we can see changes in mood related to anxiety and depression, not just because of the adjustment to disability, but also because of the changes in the hormones and production of chemicals in the brain due to the injury. And then also we do see a life expectancy reduction of about 7 years. So all of these medical complications that we just talked about can impact different areas of life. And really it's ever reaching to every area of your life. So it will impact your ability to learn and acquire new skills, interfere with your ability to engage in everyday activities of daily living. Also will have impacts on your social relationships. And overall, if we consider all of this together, it will hinder quality of life. So that's where rehab comes in. And there's many different pathways to treatment for patients. So when we are talking about the Center for Neuroskills, we can perform evaluations or complementary evaluations at any stage of the patient's recovery process. So this could be immediately following an incident. This could be in the emergency department, on an acute care or specialty floor if they've been transitioned to that level of care, or in an acute rehab or long-term rehab program. And we can get admissions from any stage. Once they are admitted into our program, there's several different treatment program options. And the one that we are going to be focusing today on is the post-acute residential setting. If that level of care is not appropriate for the patient, there's also other options such as a day treatment rehab program, outpatient, tele-rehab, and also continued care such as supported living, also aftercare, so checking in on the status of the patient afterwards to make sure that they are doing okay in the community and they have adjusted well. So residential treatment or community-based treatment can look many different ways, but it's especially helpful for patients who are going really through this identity crisis. Their whole world has been shifted upside down. Their roles in society, in their families are changing, and how can we get them back to being as independent as possible and find ways to reintegrate into those life roles. So we can see this done through community reintegration programs, post-acute care, home health, skilled nursing. There are a lot of different avenues for receiving this type of care. And we're going to talk about how do we know if the place that we're choosing is going to be successful for the patient. What can we look out for to know that this will work for them? So residential rehab really should be extending the therapy day for the patient. You know, here, patients will come and work on skills in therapy, and they'll have, you know, an hour of OT, an hour of PT, an hour of speech therapy, and they're working on restoring skills. But then at the end of the day, they can come back to the residential setting and apply what they've learned that day. So this is really where they're getting opportunity for a lot of repetition with those skills and functional practice, which to me as an OT is extremely, extremely important. We want to be using functional activities as a means and an end to therapy, meaning doing and participating in those activities of daily living is the best type of therapy to be able to achieve the goal of then doing those activities as independently as possible. The residential setting also should consider environmental validity. So, you know, having a real kitchen, bathroom, bedroom to practice these skills in is very different from doing them in a clinic setting. If you are in a more sterile environment, you know, the movements that you're doing, the sounds you're hearing, the sensory input you're getting is all going to be a little bit different than it would actually be in the real world. So being in a home-based type of residential rehab setting allows us to get closer to what that patient is actually going to be going back to once they are discharged from the program. We also look for opportunities to get patients into a rhythm of living. So, you know, everybody's rhythm of living can look a little bit different. Some people wake up really early in the morning, they go to work, they come back, they cook dinner. So it's really important to find out what types of routines and rituals that patient engaged in prior to their injury so that we can then replicate those as closely as possible. This also allows for objective learning. So, you know, when people are participating in an activity itself, it has more salience. The brain considers it to be more important than something that's simulated. And then also having 24/7 supervision by trained staff. So here we have our staff are called neuro rehab specialists, and they are caregivers who have gone through more extensive neuro rehab training, learning about the brain, learning about behavioral approaches, learning about really just brain injury specific treatment. And coupled with that skilled supervision, it's also important to have ongoing data collection so that we know that what we're doing is actually working and actually getting results. And we will go into more detail about that data collection as we move forward. So let's step back for a moment and talk a bit about neuroplasticity principles, because I want you to keep these in mind as we're talking about treatment in a residential setting so that we can see how these overlap. So the first one is we need to be promoting cortical reorganization. So we are using structure, repetition, and consistency to help the neurons to form new connections, new synapses, and reorganize around the area of the brain that is injured. So this takes a lot of repetition. The more repetition, the better, because your brain needs time to kind of relearn patterns and relearn those connections. And also the tasks need to be meaningful. One thing that we say often when we're talking about neuroplasticity is that salience is key. Salience meaning that the task is important to that person. Otherwise, your brain isn't going to pay attention to it. So those neuronal circuits, like we talked about, are modified by experience and by learning. And really harnessing this ability for this change, this plasticity that can happen in the brain is essential to getting the most out of rehab. Experience-dependent change can occur at all different levels. So when we're thinking about the nervous system, we're right now talking about the molecular or synaptic level, but it's really nice to think that these tasks that we're doing, these tasks that we're getting repetition on and practice on, are actually changing our molecular and our synaptic connections. So these kind of bigger scale activities are having really detailed, minute changes in our brain. So when we're looking at residential treatment and talking about establishing a rhythm of living, we are looking at different ways to include practice and include repetition. And part of that comes with getting into a rhythm and getting into a routine. Now, everyone is going to have different daily and weekly variations in activities. Maybe they shower every morning, maybe they shower twice a week. So all of this helps our brain to stay organized. Our daily routines help us to kind of organize our time and space, and helps us to kind of separate or chunk our time so that it makes sense to us. So for example, I know that 5 days a week, Monday through Friday, my time and structure is going to look different from my weekends. My day is going to look different from my night. And so we want to make sure that we're promoting a proper sleep-wake cycle in the residential setting, and that we're also mimicking this level of organization, such as the work week from the weekend. For this reason, our patients don't participate in therapy on the weekends. It is a Monday through Friday routine. Also thinking about life reintegration. So in the residential setting, we're looking at how can we get involved in our community? How can we promote family visits? How can we promote participation in life events outside of therapy, outside of work? And so we can do that by helping to plan outings, plan chores and routines that typically get done over the weekend, such as grocery shopping, laundry, and looking for opportunities to enact with members who are a part of the community around us. So in the residential treatment setting, we are looking at promoting independence in all of these areas. So if you think about someone who attends an OT session in the clinic, they might work on dressing, for example, on putting on a shirt. But in the residential setting, we also have many other opportunities where we can work on dressing in the morning when they get up, before they take their shower, before they go to bed and change in their pajamas. So all of these areas are able to, we're able to extend that therapy day to keep working in these areas. So bed mobility, transfers, ambulation, getting dressed, feeding themselves, toileting, and that includes bowel and bladder management, and also working on hygiene and grooming. And then we talked a little bit about getting out in the community, but we are also looking at grocery shopping or clothes shopping. How can we do meal preparation, laundry? How do we handle money? How do we budget? So our patients are on a money management program where they're given funds, $90 for grocery, $32 for outing funds, and how are they paying the clerks, making sure that they get the right change back and monitoring those receipts. And also, are they safe to be taking their medications and managing their medical appointments? So the residential setting is really providing that immediate utility of skills training, meaning they can learn something in the clinic. Maybe they're practicing, in this picture, picking up a pot with one hand because their other arm is affected, and then they can go home and immediately practice that in a more valid setting. So our ADLs and our IADLs, and by the way, that I in IADL stands for instrumental, so it's more of the kind of complex activities of daily living that we do, help us to create that structure and routine that we've been talking about is so important for that rhythm of living. They help us to develop skills because we are applying the skills that we learn in that real world setting. And then also helping us to have a structure for guiding reasoning and problem solving as we come up with, this structure and routine that we're following. So this is important because synchronization of biological rhythms really becomes unstable when your level of activity of daily living decreases. So think about yourself, maybe you've had the stomach bug for a week, maybe you've been down and out with the flu for a week, and it throws off your entire routine, right? Instead of getting up and going to work, you're laying in bed. Because you aren't moving as much, you're not sleeping as well, so your sleep-wake rhythm is off. Maybe you sleep all day and then you're up all night. And those have biological effects such as changing your heart rate and your body temperature regulation. So strengthening that sleep-wake rhythm increases the confidence of stroke survivors living in the community. And part of strengthening that sleep-wake rhythm comes with that routine and that structure from the ADLs and IADLs that we're practicing in the residential setting. So we really need to look at this as individualized as possible. When patients are coming in, we need to be asking questions like, when do you typically do your chores, right? When do you cook? When do you shop? Because we want to know what rhythms and routines are natural for them. What chores are you responsible for? So in some households, things are divided differently. Maybe someone else does the vacuuming, maybe somebody else does the dusting, but you always do the dishes. And then also, where and when are the best time to practice these skills? So when we're thinking about establishing this rhythm in the residential setting, we want to be asking all of these questions. And ultimately, establishing that routine is going to help us with that sleep-wake rhythm. And we're just going to talk briefly about how important that is, because sleep is just such a vital component of recovery and of supporting the brain as it's trying to do that neuronal reorganization. And it's an area it's an ADL that's addressed in the residential rehab facility. So over 30% of patients with moderate to severe TBI will experience some type of sleep disorder. So again, it could be narcolepsy, sleep apnea. There's many different ways that sleep can be disrupted. And all of this can have an impact on your function throughout the day. So poor sleep can lead to higher levels of anxiety. You're more easily pushed into panic mode. And when you're pushed into panic mode, your brain does not have the capacity to observe and and kind of take in all of the information around you, it has a hard time learning new information, which is what we need to be doing when we're in rehab. It also leads to higher levels of depression, impaired cognition. So excessive sleepiness makes it really hard for you to sustain attention, which is really the building block to all of our cognitive skills. And also a higher risk for hypertension, high blood pressure. And it can lead to, a variety of other disease processes as well. So higher risk for heart disease, increased risk for breast cancer, higher risk of diabetes. We're having, more unhealthy cravings when we're tired. Our body's trying to get more fats and salt into our bodies. And then also, this is something that's really prevalent in our society overall, but again, just especially for our patients who have experienced traumatic brain injury. So sleep is one area that, can be addressed through residential treatment. They are there 24/7, so we will be noticing, monitoring and documenting on their sleep quality. There are sleep devices that you can put next to the bed to help us gather data on the quality of sleep that people are getting, and we can also refer out to sleep studies if needed. And then bowel and bladder training, toileting is also another area where if someone is in a residential treatment program, this can really be monitored more closely, which is vital for a bowel and bladder retraining program. So managing incontinence starts with a tracking system. We need to know, when is the patient incontinent? Is it in the middle of the night? Is that why they can't sleep? Is it, right after they come home from the workday? What are those patterns looking like? And then we need to figure out ways to prevent that incontinence from happening so that there's not other issues that arise from that, like UTI or skin breakdown. And also addressing this will help them to restore dignity as well. So the bowel and bladder retraining, like I said, starts with tracking the information, but then also coming up with a schedule to follow. So, every other hour, we're going to go to the bathroom, whether you need to go or not. Once that's successful in reducing the levels of incontinence, we can work on stretching the time frame of how frequently we're going and trying to use the restroom. Another component of that can be managing fluid intake. So making sure that people are getting that just right amount of hydration throughout the day. So we talked about sleep, we've talked about toileting. Another area that can be addressed through the residential treatment program is helping patients to become more independent with self-administration of medications. And this is so important to reduce caregiver burden, but also for the patient's safety. If we can teach them how to safely administer medications and what things they should be checking for, we can potentially reduce medication errors in the future. So we're teaching that they need to check that the medication is for the right patient, that it's for their own body, that it's the right medication, the right dosage, and being administered through the right route at the right time. And by right route, I mean, is it an oral med? Is it a patch? How is that being administered to their body? And then also the right time. So can they initiate that at 8 a.m. and then at 8 p.m. it's time to take those medications? Because again, getting the body in that rhythm and routine is going to be really important, especially for dosing of medications. And then all of the pragmatic pieces that go along with medication. So knowing when to reorder their meds. Can they recognize when they're getting low? And can they correctly fill up the pill boxes that they're using to manage their meds once we get more supplies in? So we had touched base a little bit about cognitive rehabilitation earlier. So I do want to dive into that more. Really successful interventions in cognitive rehab allow for improvement in ADL performance. So we just talked about how important it is to be practicing the ADLs in the evening in a routine, and cognitive rehab is really the base for being successful in doing that. It helps us to be successful then in novel problem solving and to participate in meaningful activities and those important societal roles that we had discussed earlier as well. So when we look at cognitive rehab, we can approach it in two different ways. So in our clinic program, we can work on restorative properties. So reestablishing those neuronal connections, improving the synaptic connections, and strengthening specific cognitive skills. We can then take those strengthened skills and apply them to the residential setting, but we can also look at compensatory strategies. So how can we modify or adapt a task, a routine, or an environment to better suit the skills that we already have to be successful in accomplishing our daily activities? And so there's some principles of cognitive rehab that will help us to be successful, and all of these should be taken into consideration when you're in the residential environment. So looking at the environmental stimulus around you, it's easiest to perform better in a quiet environment, but we should be working up to performing in a distracting environment. The task complexity. So it's easier to start with simple, maybe 1 or 2 step tasks, and then work up to more complex tasks. And then also cognitive distance. So we want to be working from concrete activities to abstract activities. So all of these can come into play in the home setting, as well as be worked on in the clinic. And like we talked about earlier, attention is really the basis for all of our cognitive rehab that we're going to be doing. And there's different types of attention that can be addressed. So starting with sustained attention, this is how long can you attend to a task? So how many minutes can you attend reading that newspaper in the morning? If we put on a show in the evening, how long can you watch the show for before your mind starts to wander? Selective attention, so paying attention to what is most important and blocking out the things that are not important. And then also divided attention, so simultaneously multitasking. Maybe you're practicing cooking a meal in the kitchen while you also have a load of laundry going, or you are also talking with someone else or listening to a podcast. So a lot of opportunity for dual tasking. And then also we can promote use of those compensatory strategies. So in the residential setting, working out what kind of calendar are we going to use, what kind of pictures are going to be the best cues for that person. Is it going to be a handwritten note on a Post-it note? Is it going to be color coding things? What types of alarms can we set? All of these different modifications and perspective memory cueing can help us to be more successful from a cognitive perspective. So when we're thinking about our executive functioning, which is all of the kind of complex time management planning that happens, we can utilize those strategies to help us build those skills and be successful. So when we're looking at planning deficits, that's something that could be addressed through different planning sheets, leisure outings, working on shopping, also sequencing, so using really detailed checklists to make sure that you're doing things in an appropriate order. Time management deficits, so using those alarms, using those checklists or planning sheets, and then also addressing decreased self-monitoring and self-awareness. So there's 3 different types of self-awareness that we can be working on in the residential setting. One is your awareness of your own body and what you're doing in space. Another would be social. So how are you interacting with different family visitors or even a roommate? And then also that introspective awareness, kind of giving feedback to yourself about your performance. So all of this comes together to say that in residential, we are requiring skilled instruction on a daily basis, where we're allowing for that repetition so that neuroplasticity can occur. And we're documenting progress so that we know what we're doing is working. And all of this will promote recovery and also ensure the patient's safety. So practicing skills helps us to master multiple skill sets, and that mastery can lead to self-efficacy, independence for the patient. Confidence in what they're doing is correct. So when we have staff with them in the evenings, kind of being there as a support system, we're able to give them the confidence to approach difficult tasks, sustain effort rather than giving up and asking someone else to do it for you. So we're putting an end to shying away from the challenge, dwelling on their deficiencies, and really not letting them give up. This is just an example of a daily checklist that might be used. So we are using the top section where you have the different days as a little bit of an orientation practice. So you can circle what day it currently is and then kind of check off the activities as you go along. Now, when we're talking about documentation and monitoring progress, we have developed a system of scoring where there's a scale called the Independent Living Scale, and it's a scale that's scored on a numerical range of 0 to 6. 0 meaning the patient is performing the task independently, and 6 being that they're performing it with maximum assistance. And this is how we can keep track of that progression toward independence, and also validate that whether we need more time or don't need more time with someone. So what you see here is a breakdown. This is a sample page of scoring for a patient, and you can see that they're being scored in the areas of hygiene and grooming, toileting, dishes, time management, travel, laundry, shopping, phone use, mail use. We're really hitting every area, as well as tracking their behaviors to see if any maladaptive behaviors show up during these activities. This score can be broken down in a variety of ways because it is so detailed. We're not only scoring on the activities, but each task in each activity. So if a person is taking a shower, that's their current activity, are they successful in the task of turning on the water, of adjusting the temperature, of getting in safely, of using the shampoo correctly? So every little piece is taken into account. And those little detailed scores help to make up a much bigger picture of performance, and we can watch those scores change over time. So in this example, you can see in the chart with the green and the blue line in the circular chart, where their scores were at on admission versus their current scores in all of these different areas. So this scoring system really gives a vast amount of information for us to go off of. So really, why do it any other way, right? There's all of these benefits to residential treatment, ultimately affecting the patient's outcomes and leading to cost savings. Because if we do it right the first time, if we give them enough opportunity for repetition the first time, we're not seeing as many readmissions. We're seeing reduced disability. We're seeing improved quality of life, and integration back into work, school, and ultimately success in elevating quality of life. So some key points from considering residential rehabilitation as a whole is that prematurely interrupted or inappropriately protracted periods of residential treatment are equally likely to undermine cost effectiveness, and timely intervention is the key to use of limited resources. So meaning we need to have an extended period of time where we can really do things right, keep it consistent, keep their routines, and keep that repetition going, because ultimately that is what's going to lead to the cost effectiveness of the program. And then these programs are really an essential component to that care continuum, because they are offering extremely intensive services, more in a community-based setting. So it can act as a step down from that acute care inpatient kind of hospital setting that they might go to after their initial injury. And then post-acute residential rehab was associated with a wide range of improvements, including progress in place of residence, people going to the least restrictive environment, functional independence, and then performance in their social roles. And then there are several meta-reviews of post-acute residential rehab that have concluded that rehabilitation brings about significant gains in terms of personal autonomy, the ability to return home, return to work, and participate in family life as well. So life after CNS, so this study was conducted with a population of 153 of our patients, just to kind of show you the improvement that was made in the residential setting. 16% of these patients had admitted in a wheelchair, and at the end, 94% were ambulators. So we're not using that wheelchair any longer. 11% of patients who admitted were incontinent, and we resolved that for 59% of those patients. For their diet, 12% were admitted on a modified diet or nothing by mouth, and at the end, 94% were eating a regular diet with thin liquids. 29% of our population returned to work. 17% returned to driving. And then if you look at the discharge disposition at the end, 93% of them went home and didn't need care from an acute care setting or a SNF. So those numbers kind of speak for themselves there. And that concludes the presentation. I do have the references and resources used in the presentation in the handout. You'll see them on the PDF handout that you have.
That was an outstanding presentation. You gave so much information. It is mind-boggling how much goes into rehab, every little thing that we don't think about. So many people, I have a podcast, it's called White Knuckling It Through Life, and we spoke to a woman who had a stroke, and she had to be in a rehab facility for like a year or something, and every little thing has to be relearned. I pray that never happens to any of us or any of our listeners today, but that was so thorough. Thank you so very much for that. Dane, is there anything else you'd like to say?
Well, I had just two little questions that might be of interest. I was going to ask Alex, how often does the clinical therapy staff and your residential staffs, how often do they meet to discuss a patient's progress or any challenges they might be having?
Yeah, that's a great question. So communication really has to happen on a daily basis. So we have several different avenues for that communication to take place. One is over the computer, constantly sending updates. We call them hot issues. So they're things that are really important to communicate about the patient that day. And then also meeting daily to just go over general program changes, updates, and goals for the patient. So that's really happening every day.
Great, thanks.
All right, well, if there's no other questions, I would like to thank Alex for the outstanding job that you did. I see that someone, Angie Lim said, thank you for the great information. So she's echoing what I'm saying. It is great information. And Dane, it's always great working with you. And I don't think we want to go another 20 years, but
No.
you know, just for a lot longer, right?
That's right.
Maybe
No.
we'll be doing this at least another 10 years together. All right,
That's
everybody. We'll see you later. Bye-bye now.
Thank you.